I want to welcome everybody to the first inaugural PESTOLA for Pediatricians conference. This is going to go from, around 8 o'clock, which is now, until somewhere around 12:30. We want to get you guys out of here so you can either get to clinic if you have clinic this afternoon or at least lunch. So we want to thank the PESTOLA board for allowing us to do this. This has been a labor of love for us. Yeah, I can't make it work. It's on, but it's not. Do you think that is? Run this up. So we want to thank the PESTOLA board for allowing us to do this. This is kind of a labor of love for my division over the past 2 years. We've been trying to generate something like this because it just felt a good time for us as we grew from 4 endocrinologists to 8, that we reach out to our pediatrician colleagues and kind of touch base on a few topics that are important to them in clinical practice, give them some pointers, or at least from our perspective, what are good approaches to common endocrine issues. We started this 2 years ago. PESTOLA approved it about 15 months ago. We put it up for people to start signing up, and at about January 1st this year, we had about 7 people, which was a little disappointing to us. We were kind of disheartened and said, well, maybe we shouldn't do this. I mentioned it to Greg Sharp and Rick Barr and some of the other division chiefs at Arkansas Children's. We put the word out with all of our other colleagues, and we went from 7, which today our last sign-up rate was 58. So I was very impressed and very grateful and thankful for the initiative that people took to help us out. A few housekeeping items. I have to write them down. Of course, we know where the bathrooms are. You guys are welcome to get up. They're just around the corner right where you registered. If you are interested, the symphony is going on in the Robinson Center Saturday night at 7:30. They still have tickets, so if you want to go do that. And the last item is the CME. So make sure if you didn't sign in at the registry at the table up front, please do so before you leave, and then turn in the evaluation paperwork so you can get your certificate. With that being said, we're going to get started. Our first topic is a duo of Dr. Amir Toss and Dr. Shipra Bansal. They're going to talk to us about thyroid.
Good morning. Good morning. There are advantages of being short, so you can be close to the microphone. It's exciting to be the first speaker, actually. Thank you all for being here. And I'll talk about congenital hypothyroidism. I have about 10-15 minutes, and then I'll pass the word to Dr. Bansal. I have no financial relationship to disclose. However, I am a consultant physician for the Department of Health Newborn Screening Committee. And here are the objectives of my talk. All right, I'd like to start with some of the statistics from Arkansas. Here in this pie chart, you see the total number of cases diagnosed to have a congenital problem through newborn screening program in the last 11 years. So each pie represents different years. So this green here, number 67, is from 2009 and going in the clockwise direction all the way to the last year, fiscal year 2019, with 105 total cases. Out of these 910 confirmed cases of congenital problems in the last 11 years, 396 of them were congenital hypothyroidism. So in other words, about 40% of the confirmed cases of newborn screen were congenital hypothyroidism. And if you just specifically look in fiscal year 2019, out of these 105 confirmed cases, 66 of them were congenital hypothyroidism. So I think these numbers are telling us that congenital hypothyroidism is one of the commonest congenital problem that's being diagnosed through the newborn screening program. And these statements are from the Arkansas Department of Health website. Congenital hypothyroidism is a condition or a disease which causes irreversible brain damage and mental retardation unless it's detected and treated at a very early stage in the life of a newborn individual. And I underscored at a very early stage in the life. There's really no clear-cut definition of this early stage. So there are a lot of literature out there, which I'm going to discuss a little bit later. And CH, congenital hypothyroidism, is one of the most common preventable causes of mental retardation. Thyroid hormone is essential for many metabolic functions, but it is essential especially for the normal growth and development of the fetus and the newborn babies as well as toddlers. And besides that, thyroid hormone has some other functions as listed in the slide. So here are the clinical manifestations of an established congenital hypothyroidism disease. Well, most of these babies are often described as good babies just because they don't cry. They rarely cry. They sleep most of the time, and they may or may not have any signs or symptoms of congenital hypothyroidism at birth. Decreased activity, large anterior fontanelle, prolonged jaundice, hypotonia, coarse facial features, microglossia, and some others. But these are signs and symptoms of an established disease. So once an affected baby presents with such a sign and symptom, it kind of actually tells us the severity of the condition. So most of the babies, if not all, have no symptoms at all. And that's the purpose of newborn screening, to detect these babies even before they become symptomatic, so we can treat on a timely manner. So as said, majority of the newborns with CH do not have obvious manifestations, and that's likely due to transplacental passage of thyroid hormone. Therefore, the clinical diagnosis is difficult, so screening is crucial to identify these babies. And obviously, delayed diagnosis puts the brain of the newborn babies at risk for injury from hypothyroidism. And as a result, treatment should be started as soon as possible. This is a classical picture of an affected baby with hypothyroidism before the screening became routine. So on your left-hand side, you see some of the classical physical exam findings of an affected baby. So coarse facial features, the baby is puffed up. I see the tongue is protruding, it's kind of microglossia. And after treatment began, some of the symptoms or signs have disappeared. However, this baby was noted to have moderate to severe mental retardation, unfortunately, just because the diagnosis was not made until after the symptoms were established. In the seminal paper from 1972, here on the top bar graph, this is the average IQ of the control group or unaffected babies. And here is the average IQ, mean or median IQ of the babies affected with congenital hypothyroidism. So delaying diagnosis for a few weeks to a few months causes significant decline in the IQ of the babies. In developed countries, most babies are diagnosed through the newborn screening program. However, only about 25% of the babies are born in developed countries. So meaning that 75% of the babies born elsewhere, not in the US, not in developed countries, basically they are not going through routine screening program. So how do we screen the babies with congenital hypothyroidism here in the United States, in Arkansas? As you're all aware, we do that through the heel prick blood sampling that are collected after the first 24 hours, and usually between 24 to 36 hours of life. And they are all mailed to centralized laboratory at the Department of Health in Little Rock. There are 3 different approaches to screen for congenital hypothyroidism. Here in Arkansas, in most other states, we have adopted primary TSH and backup T4 method. So what it means, we basically measure the TSH in the filter paper, and if the TSH level is above the threshold for that specific age, we then measure T4 level. And I'll show you an example of a newborn screen, an abnormal newborn screen for CH. There you go. So it's a little bit small perhaps, but this is the report that the Department of Health shares with the primary physician of an affected newborn. So demographics of the newborn baby, including the gestational age, the birth weight of the baby. Let's see, that's something. Okay. And here it reports the TSH value of the baby as 189 for this patient. And they also report T4 value of this baby, which was 14.3 for this patient. And as you could see, TSH was flagged as abnormal, and T4 was flagged as normal. And here on the bottom, you see the recommended actions from the Department of Health. Highly elevated thyroid stimulating hormone, further testing is indicated. So once you receive such a letter from the Department of Health, basically contact with the family and recall the baby for immediate evaluation, examination. But remember, these babies are not going to have any signs or symptoms of thyroid problem. Confirmatory blood test is usually TSH and free T4. Sometimes we are seeing some other tests are also being ordered. However, these two are more than enough actually to confirm a diagnosis, TSH and free T4. And all textbooks and guidelines say that the initiation of hormone replacement treatment should not be delayed until confirmatory results have returned. So in other words, start treatment just based on the newborn screening results. However, when we did a survey of the community pediatricians and providers last year through the Department of Health, 75% of the respondents said that they prefer to wait the results of the confirmatory blood test before starting the thyroid hormone replacement. So, and I think there's a basis for that. Perhaps when the guidelines were written, it was taking days or weeks until the TSH and free T4 levels come back. But now, we have the results of TSH and free T4 levels be back within hours, even before actually the patient makes the pharmacy to pick up their medication. However, don't get me wrong, I'm not saying that wait until after TSH and free T4 are back, but it's best to basically understand your logistics and go from there, basically. Here in this table, I am just showing you the number of newborn screening in the last 6 months and positive results for congenital hypothyroidism. So in the last 3 months of 2019, 315 babies tested positive for CH. However, only 9 of them confirmed to have CH based on the confirmatory blood testing. So if you follow the guidelines, all 315 babies would have started thyroid hormone replacement. But if you have the results of TSH and free T4 within an hour or so, then I think you understand me. So just basically you balance your decision. So the timing of treatment initiation and frequent monitoring of thyroid functions are crucial to ensure the best neurodevelopmental outcome, because there is an inverse relationship between the age of diagnosis and treatment and IQ of the affected baby. Before screening became established, mean IQ of affected babies were only 89 when they were diagnosed around 3 months of age. And as the diagnosis got delayed, as you could see, the IQ of the affected babies significantly declined. So earlier the treatment begins, better the outcomes. And in general, we would like the baby to start treatment within 3 weeks of birth. And that's what most guidelines and recommendations are basically based on. Thank you.